And this is sort of by way of introduction. I'm sure y'all are very familiar with this, but it's to compare the sinuses in young children versus adults. And these would be the maxillary sinuses, the large ethmoid sinuses with the middle turbinate and your osteomeatal complex here, which is where the sinuses drain into the nasal cavity. We have the anterior ethmoids and then posterior ethmoids with the sphenoid, frontal sinus, and sphenoid sinus. And that is in distinct comparison to very young children who have a very small maxillary sinus. The anterior ethmoids and maxillary sinuses are present at birth in children, though, as you know, the frontal sinus and the sphenoid sinuses are not. Those two sinuses sort of begin to develop between 4 and 6 years of age and usually don't reach full size until adolescence. The ethmoid and maxillary sinuses also grow over time, and particularly the maxillary after the secondary dentition come into place, and there's a lot more room for there to be hollow air space in the sinus cavity. And a couple of things that we need to talk about before we leap right into antibiotics and surgical and medical therapy for sinusitis, talk a little bit about the physiology of the nose. You guys have lots of other things to think about with your patients. This is all I think about all day. Basically, mucociliary clearance, and that basically is mucus flow in the nose. And as you're aware, the respiratory epithelium in the nose is columnar, pseudocolumnar, and ciliated. And on top of these cilia is a little blanket of mucus. And that blanket of mucus basically flows out in sort of a constant flow pattern up through this area called the osteomeatal complex. And there's a little bone called the uncinate process, and there are ethmoid air cells here that can sometimes be offending and obstructing parts of the sinus drainage pathways. And over here, a comment just on things when you look in these kids' noses, sometimes they're turbinates and the tissues in the nose seem very congested, and other times they may not, even in the same patient, even on the same day. And that's because there is actually cycling of the congestion in the nose. In adults, it's very regular, right to left, and it kind of each side sort of goes up and down. But in children, it's very poorly regulated, and it has to do with the capillary beds and just not having the congestion well controlled. And it can increase quite a bit during puberty. And those of you who may remember if you did med peds or something and you took care of ladies that are pregnant, a lot of them have stuffy noses, and that's partly due to this poor vascular control in the nose. So, snotty-nosed kids. Basically, the list on the left is sort of the typical diagnoses that I see in patients when they come to my office. And it's my job to sort of generally to kind of decide what it is from the long list on the left side. And acute bacterial sinusitis is the main focus of today's talk. We're going to try to hit on the essentials of that. And this is essentially a classic picture of bacterial sinusitis. Down here would be the inferior turbinate that you see when you first look in the nose. This is the septum. Here's the middle turbinate. And there's this creamy pus right under the middle turbinate. And the rest of the nose actually doesn't look that unhealthy. And that's not untypical for true acute bacterial sinusitis when they're past the viral illness and other things that make the nose so congested and mucousy. So that's the main topic that we're talking about, but obviously many of these children have acute viral rhinitis. Some of them are going to turn out to have atopy or allergy conditions. They may actually have a chronic or recurring subacute type of bacterial infection. Chronic rhinitis is really a diagnosis we make in very young children who do have chronic bacterial infection of the lining of the nose. It doesn't affect the sinuses per se. Sometimes patients may just have bronchitis or other respiratory tract illnesses. And finally, a couple of the things, primarily in patients with unilateral symptoms, don't forget that they can have a choanal atresia or a congenital obstruction of their nose. They can have stuck something in there and have a nasal foreign body, or they may have a dental abscess, and that will certainly cause maxillary sinusitis. And I've alluded to this, but it's always nice to see a picture of the actual pathophysiology. Why and when do patients get sinusitis? Well, primarily the osteomeatal complex, which is sort of this whole area in gray on the slide, but particularly here, it's a fairly narrow opening that all of your mucus from your sinuses need to escape, this being part of the ethmoid air cell called the bulla, and this being your uncinate process. middle turbinate, inferior turbinate. Basically, it has to keep flowing, and so this area in here, anterior ethmoids and uncinate process, when they become obstructed due to allergy, many of the other things on our list, acute viral rhinitis, allergic rhinitis, atopic rhinitis, chronic rhinitis, even patients with choanal atresia, anytime there's this mucus congestion and obstruction in the nose, you can develop a bacterial sinusitis. So, how can you figure out who has sinusitis? Primarily, the symptoms in young children versus old children are a little bit different, and I've added a little something on the slide to come out of something y'all will be familiar with, which is the American Academy of Pediatrics Guidelines for Sinusitis. And in those guidelines, you may be more familiar with the term persistent symptoms versus severe symptoms. And when I was looking at the guidelines, I noticed that it sort of correlates pretty nicely with the age of child and the disease. Primarily in young children, they're going to have upper respiratory tract infectious symptoms for greater than 10 days, or in the case of chronic bacterial sinusitis, they need to have it consistently for greater than 12 weeks to make this diagnosis. And the most common symptom is going to be purulent rhinorrhea, green snot. Not clear stuff, just the continuous green purulent rhinorrhea. And they also typically will have a daytime cough. Parents may also complain of halitosis, that their kids are congested, they might be irritable, and may also run a low-grade fever. In older children, at least for acute bacterial sinusitis, this is over the age of 6 or 8, you're going to start hearing them actually complain of headaches or facial pain. You may start to notice that they have cough at nighttime that's keeping them awake at night, congestion, rhinorrhea, and all of those for patients that have greater than 10 days of upper respiratory tract symptoms, and patients particularly who have severe symptoms, fever that's not just a day or two, but 3 to 4 days of high fever or a very chronic low-grade fever. And kids with asthma may present with an exacerbation of their asthma. So how do you make the diagnosis if you think but you're not sure? Well, it has been pretty typical in the past to order plain films. And unfortunately, there are some drawbacks to that, and that is that in a study where kids had plain films, basically Waters views or 4 views of the sinus, compared to CAT scan, there was a 75% discordance with plain films to CT scan. Part of the time that was that it was an abnormal plain film and they had a normal CAT scan, and part of the time it was that there was a normal plain film and an abnormal CAT scan. And so in the American Academy guidelines, it is recommended that plain films not be used in children under the age of 6 because it provides basically limited clinical utility. In older children, it may be helpful for identifying air fluid levels, and part of that is because their maxillary sinuses are larger and it's going to be more easy to tell a true air fluid level from just bone and teeth and other things that cause soft tissue color on the plain film. And it's not a useful test for chronic sinusitis. By contrast, a CAT scan is considered the gold standard. These are typically coronal views and without contrast. You do not need to give these children contrast unless you're suspicious of a complication of sinusitis. If you do suspect cellulitis or an abscess, they do need the contrast with their scan. And these films are very sensitive, but they're not at all specific for the diagnosis. A patient with a viral respiratory tract infection may have very similar sinus films to a child with acute bacterial or chronic bacterial sinusitis. And this is just a few data to kind of help put that in perspective, is that within 6 weeks of an upper respiratory tract infection, 40% of all children will have an abnormal CAT scan. That's based on kids getting CAT scans for headaches and seizure disorders and non-sinus related symptoms. 15% of all asymptomatic children will have an abnormal CAT scan at some, take now, CAT scan all the kids in your practice. Those without any nasal symptoms, you're going to find 1 in 8 of them are going to have an abnormal scan. And especially in very young children, in part because the sinuses are not well developed and it's hard to read, you're going to note that most of them have an abnormal scan. So it's a gold standard, but when do you use it? It looks like I've kind of knocked out all the reasons to use a CAT scan. Basically, the best time to use that is if you are suspicious of a complication. Their eyes gotten swollen. You want to know if it's preseptal cellulitis versus some bad orbital abscess. they're acting weird and you're worried about an intracranial complication of sinusitis, or some other similar orbital, intracranial, or bony complication. When you're contemplating surgery, you're considering referring them for surgical intervention for persistent sinusitis, and in patients where you're considering that there's a chronic infection. Not included in your guidelines, but I would throw in there is that when I see patients in my practice for routine headache, but the nasal exam is fairly normal, then sometimes I'll do this as a screen, and if it's abnormal, then I'll proceed with medical therapy and use a scan that way to kind of help direct my management of a patient. So if you think a patient has sinusitis based on the clinical presentation and examination, how are you going to treat them? Well, your treatment is going to be based on the natural history of the disease, and the natural history is that 40% of these get better on their own, but it really depends on the organism which ones get better. Patients with strep pneumo, which is the most common organism to cause sinusitis, they don't get better nearly as often on their own as those with some of the gram-negative organisms. And why do we use antibiotics? We use them to help patients get better faster, right? I mean, you don't want them in your office all the time. And you want to treat them particularly if they're having very persistent or very severe symptoms. And so the treatment guidelines, according to your academy, is amoxicillin in a high dose, 90 milligrams per kilogram divided BID. The treatment is 7 days after the symptoms resolve. And what that means is that the 10-day course that is typically given for sinusitis is probably not enough most of the time. More typically, you're going to need to treat for 14 to 21 days. The other things that you may want to do to sort of help your patients feel better and get better faster is that using nasal salt rinses may help mucociliary clearance. It has been shown in some of the meta-analysis for viral respiratory tract infections to be helpful and patients feel more comfortable. You may recommend providing room humidification, especially if it's very thick mucus and they're quite congested. The remaining, using decongestants, that's a little controversial. Most of the review studies show that it's not very helpful. I have to say I was trained to use decongestants, and I use them typically topically for a couple of days to help improve drainage, but that frankly has not been completely proven in good meta-analysis. Patients who also have allergic conditions definitely need them treated. Otherwise, they're not going to probably get over the primary reason they developed sinusitis in the first place. And the main thing you're going to be using is nasal steroid preparations. It is important to note that antihistamines probably should be avoided in true bacterial sinusitis because they thicken the mucus and will contribute to obstruction of your osteomeatal complex. This is sort of to give sort of some reasoning from the CDC as to why that 10-day period has come out as part of the reason that you should be not giving antibiotics with respiratory tract infections for 10 days. It's not just to torture your patients. The main reason is that by 10 days, the two primary symptoms of fever and sore throat from the postnasal drip are better, and the cough and the nasal discharge are on the decline. However, note that at day 10, there really still are a fair number of kids that have had a viral illness that continue to have those symptoms without having secondary infections. And if you look at the addition of an antibiotic to benefit these patients, you'll note that the yellow sputum and rhinorrhea actually doesn't get that much better when you compare placebo to doxycycline use, except at day 5. There is some suspicion that maybe you'll be helping them out on one of those days. And of course, what conversation about infectious disease these days would be complete without a discussion of resistant organisms? It's a growing problem in our community. Apart from not over-treating viral illness, it's important to be aware that there are many patients that have true acute bacterial sinusitis and may not get better if you start them on high-dose amoxicillin therapy. And so when should you consider that they're not getting better? Well, obviously, if they continue to have a high fever, they're continuing to feel horrible, they're not improved at all at 48 hours of your empiric therapy, you're going to want to consider that they've developed a resistant organism. Anyone who initially gets better and you stop antibiotics and within a week or two they're ill again, you may want to consider that they've had a resistant organism that was improved but not cured. And in all cases of complications, the more virulent strains are going to be more likely to cause your orbital complications. And so just like in otitis media, there's a higher rate of mastoiditis when resistant organisms are the cause. You're going to have the same increased rate of complications with sinusitis. And so in considering these resistant organisms, you want to look at the fact that strep pneumo, which is the #1 cause of your cases of bacterial sinusitis, 25 to 50% of them are going to be penicillin resistant. Now, you get about half of these using high-dose amoxicillin because about half of those are going to have intermediate resistance to penicillin and are going to be sensitive to the high-dose amoxicillin. But you're not going to get all of them, and so you'll need to go to something that has that doesn't have that is not sensitive to the penicillinase. And in the cases of H. flu and Moraxella, most of them are beta-lactamase resistant, and so you'll have to move to something that has beta-lactamase coverage. And so essentially what we're saying is that you're going to have to move up to something like the amoxicillin with clavulanate, high-dose amoxicillin with clavulanate, an extended second-generation cephalosporin or a third-generation cephalosporin, some of the macrolides, and changing your therapy. It is always interesting that patients frequently receive nasal cultures, which are very helpful in identifying carriers of MRSA in daycare settings and other things that can be passed around the community. But unfortunately, in illness, that does not correlate with what's actually growing in the sinuses. In a setting where you had a very good patient and you're able to actually put one of the little micro swabs up under the middle turbinate to that little creamy picture that I showed you in the beginning, that culture actually correlates in many, many cases with the cause of bacterial sinusitis. But once the pus has sort of sat in the nose for a while and all the secondary organisms that are growing in your nose start growing in it, you're not going to really identify the organism of your sinusitis. Okay, switch gears here for chronic sinusitis. And so I guess at the end we'll kind of give a summary slide, but it does mean that in a lot of ways you're sort of in a rock and a hard place with these kids. Most of them have upper respiratory tract infections of viral etiology, but some have bacterial sinusitis. X-rays are not very helpful in diagnosis. So you really have to go with your clinical judgment and treat with antibiotics when you think it's indicated and follow patients for complications and for improvement with your therapy. In treating the patient with chronic sinusitis, and I put this in because it's always of some interest, these are patients, as I've said, with greater than 12 weeks of symptoms of headaches, facial pain, maybe low-grade or high-grade fever, congestion, nighttime or daytime cough. The history and exam is going to be very similar to acute sinusitis, and particularly when you're doing your anterior rhinoscopy, you're looking for the same things that you were looking for with acute sinusitis, but you're also looking for foreign bodies and polyps, other causes of obstruction of the nose. And when they come into my office, we typically do nasopharyngoscopy with a telescope, look all the way back to the adenoid area and rule out narrowing like choanal atresias and things like that. And for making the diagnosis of chronic sinusitis, we recommend that the CT scan of the sinuses be performed after you've completed your medical therapy, because what you're looking at are these patients that are medical failures that need a surgical procedure to assist them in curing their disease. The empiric coverage is going to be similar to acute sinusitis, except that they've had it longer, they're more likely to have resistant organisms, and they're much more likely to have mixed infections with multiple organisms. And so you really are going to want to provide fairly broad coverage for these patients. Most typically we'll start with high-dose amoxicillin with clavulanate therapy or substitute a cephalosporin alternative. Some cases when there's an allergy, clindamycin doesn't have gram-negative coverage, but it does cover the resistant strep pneumo, and your anaerobes may be helpful, and you can consider the macrolides. These patients generally are started on a minimum of 21 days of therapy, but often this can go to 6 weeks continuous, because you want to see if you're going to get them symptom-free for 7 days. If they're not symptom-free at the end of I may not every time go to 6 weeks. If they're really having no improvement by 4 weeks, I'll usually go ahead and get the CAT scan looking to see if they need surgery. If they really are starting to get better, do continue it out to 6 weeks and see how your patients do. we always, certainly when they come into my office, and I'm sure you do the same thing, you're always looking for reasons why did this patient get a chronic bacterial infection. And the first reason is primarily allergies. That's the most common comorbidity. But additionally, patients may have cystic fibrosis. As more genotypes and phenotypes of cystic fibrosis are identified, we're finding that even teenagers who have not had any gastrointestinal tract or asthma-type symptoms may have cystic fibrosis. And so before doing surgical therapy, we almost always recommend that a sweat test be performed. Or in very suspicious cases, if the sweat test is equivocal, we'll go ahead and do serum genetic testing. There are rare diseases such as immunodeficiencies, primary ciliary dyskinesia, and cartagenars, which are also always sort of in the back of one's mind, and you consider chest X-rays, ciliary biopsies, and blood work for the immune system to help identify that when that's a suspicion. And I thought I'd throw a picture up of nasal polyps. I know sometimes you guys don't get to see these things. This is the lateral nasal wall. This is the septum. This is the middle turbinate. So this is a telescope looking up. The inferior turbinate would be down here somewhere. What you're seeing is this sort of jelly-like lesion. It's almost like there's two middle turbinates, and that's the polyp right there coming right from the osteomeatal complex. And you'll see polyps in a number of conditions, but in a child it should always make one think about cystic fibrosis, and it's essential to rule that out. They may also have can be due to allergies. It can be due to a type of infection called allergic fungal sinusitis, where they truly have an allergy to fungus that's in the environment and develop very bad sinusitis, often unilateral, and you can sometimes see them in immune deficiencies. And just to remember, you guys can always order a chest X-ray, especially if patients have other things that make you think about an nodal cilia symptom. Talked about nasal saline. A lot of times when I talk to pediatricians, they ask me, well, how do you do it? What's the recipe? So I thought I'd throw that up here for you guys. 2 to 3 teaspoons of a non-iodized salt in a quart of warm, clean container, warm water. And there are a number of ways to distribute it. Here's a picture of an adult using a bulb syringe, but kids do pretty well with a neti pot, which is like a little teapot that you can get from the health food store, bulb syringes, atomizers, lots of ways. The medical management, basically, it's the same as acute sinusitis, except with an additional alertness for atopic and allergic conditions. And you'll often add a mucolytic, such as guaifenesin, especially in a teenage patient who can take a time-clear-release tablet for that. And again, saline and humidification. And for those who are failing all of that, in these cases, we're always thinking potential surgical therapies. Especially in younger children, but in all children who have large adenoids, removal of that may be all that's necessary to treat the disease. And in some cases, a drainage procedure will facilitate healing, although that usually on its own is not enough. Endoscopic sinus surgery, which is the main thing that we do for children, does provide an opening and drainage, but they still need to continue allergy management, saline, hygiene, and antibiotic therapy before and after their surgery. And just thought I'd throw a couple of pictures up here. This is the septum. This is the very back of the middle turbinate. This is where you would see an obstruction if they had choanal atresia, but really what you're seeing is an obstruction because they have enormous adenoids, and this child would benefit greatly from removal of the adenoids. And for sinus surgery, also to kind of give you a picture of what we do, this is the middle turbinate. Y'all been seeing that today. And this is the lateral nasal wall going down to the inferior turbinate. This is kind of a hole, basically, where that little bone was removed so that the pus can drain more easily into the nose. And then here's the bulla. This is the middle turbinate right here. This is that air cell that I pointed out could make your sinus opening narrow. And this is starting to be open, but then we would completely remove that so that, in fact, here's the bulla there, not removed. So if you open that whole area, then they can have it will facilitate drainage. So in conclusion, I thought I would put on something y'all be familiar with. If you heard Dr. Ellen Wald talk this last year, you've already seen these recommendations, but I thought it was a nice end. There's always conversation when guidelines come out. Everyone doesn't agree with every point, but I think it's a fairly good summary of how we in otolaryngology treat sinusitis, and it's delightful to see the Academy of Pediatrics basically discovering the same things that we know. The diagnosis, well, sorry. Sometimes fields don't always agree about things, and I think it's wonderful when there's a partnership. Nonetheless, the diagnosis should be based on clinical criteria in children with upper respiratory tract infections that either have persistent or severe symptoms. Imaging studies are not necessary to confirm the diagnosis of acute bacterial sinusitis in young children. CT scans should be reserved for patients in whom surgery is being considered for recurrent or persistent infection complications. We've kind of talked about this. Number 4, antibiotics are recommended for acute bacterial sinusitis to achieve a more rapid clinical cure. 5, children with complications of acute sinusitis should be treated promptly and aggressively. I'm sure there's no surprises here, which I didn't talk much about this. And we would obviously refer the patients for referral to the various specialties that would be involved. Neurosurgery if it appeared to be a brain abscess, ENT if there appeared to be an orbital abscess, or if the patient needed culture and drainage, infectious disease to help with management of the antibiotics, and ophthalmology for examination in eye complications. There are no recommendations made about adjuvant therapies, and that would include some of the things I've talked about, decongestants and saline. There are no recommendations about alternative or complementary medicines, and there's no recommendation about prophylactic antibiotics because the data is really basically too controversial and there's not enough good meta reviews.